So students, we have already done the 3 parts of NSAIDS, and I hope you are able to understand everything. And a very good afternoon, all of you, and hope you are enjoying the comfort of your home, because they say that there is no place better than home. It's a place where you get to make long-term relationships with your parents, with your siblings. So what more we want? So one must be a home-loving person and be at peace at home. In the wake of COVID-19, where there is a lot of panic to go out, or even the government has made a lot of restrictions, which I think is very good in relation to social distancing, I am here again to talk about the individual NSAIDS. Learning, is limitless. There are no boundaries. So you can read this, you can go through this PowerPoint at your convenience, at your time, and as many times as you want, so that your concepts are clear and you have not to lose with respect to learning in the present epidemic. So students, I tell you, please devote all your time to studies, because that is what is going to make good doctors out of you, who can serve the society and derive satisfaction from patient care. So we are now going to go for the individual NSAIDS, and in my previous session, in the lecture session 3, I have already covered aspirin, and I think I've already covered paracetamol. So some few of these NSAIDs, this is a chemical classification. I'd like to cover Diflunisal, KETOROLAC, INDOMETHACIN. We would also like to cover diclofenac and ibuprofen, and these long-acting congeners, Oxicam and Meloxicam. Sometimes they can also be asked to you as short notes, so that is why a little bit more specificity about these drugs is required. Now we come to the aspirin derivative. The first and foremost is Diflunisal. Diflunisal, as you know, is derived from nothing but salicylic acid. It is more potent than aspirin with respect to inflammatory action is concerned, but it is not an irreversible inhibitor of COX. It appears to be a competitive inhibitor of COX. So it is unlike aspirin, it is different from aspirin. And also the other difference between Diflunisal and salicylic acid is that Diflunisal cannot cross the blood-brain barrier, so it will not be an effective antipyretic agent to be given, because you know that antipyresis is brought about by inhibition of the COX-3 subtype in the brain. So if that is not attained, then antipyretic action would lack somewhere. So Diflunisal may be a good anti-inflammatory agent, but it is not a good antipyretic. Rather, I would say it is devoid of an antipyretic action. The first sign of aspirin overdosage is tinnitus. As you know that aspirin overdosage causes tinnitus. So because of that, we get tinnitus as one of the side effects of aspirin, but with Diflunisal, such things are not encountered. It also causes less GIT and less GIT problems, and its antiplatelet effects are also less as compared to aspirin. The reason I think you understand well, the initial dose is 500 to 1000 milligram, followed by 250 to 500 milligram every 8 to 12 hours. So that is the dose of Diflunisal, and just keep a note of it and just try to establish its difference with aspirin and with aspirin. Yeah. Its maintenance dose should be less than 1.5 grams per day. Now we come to the propionic acid derivatives. We do have many propionic acid derivatives, but to top the list is ibuprofen. Ibuprofen, is having a good anti-inflammatory action, but at the same time, it is also having less GIT irritant action as compared to aspirin. Ibuprofen is the second agent to be approved by WHO for the treatment of pain associated with osteoarthritis. It is also safe to be given in children in case you want a fever reduction in children. It has been WHO approved. And as I recapitulate from my previous class, that it is contraindicated in individuals with nasal polyps, angioedema and bronchospastic reactivity to aspirin. The reason is very simple, that it can cause more incidence of aspirin asthma or NSAID-induced asthma. So that is very high with ibuprofen, higher as compared to the other NSAIDs. It can cause tinnitus like aspirin. It can cause dizziness, headache. You know, these are the drugs which we give for the treatment of headache. They themselves can cause headache in return. So what we can expect from these drugs is just a small point to ponder over. Of course, you know, body has a tremendous capacity to get over the side effects of the drugs. You know, if you give the sedative hypnotics for 2 to 3 days, patient does feel sleepy throughout. He feels a sense of hangover. But gradually, as we give the drug, the body develops tolerance to it. So body learns to tolerate the side effects of some drugs. So that is about ibuprofen. It is supposed to be linked with aseptic meningitis, and it is also linked to fluid retention. I have already told you that NSAIDs, they can cause fluid retention because they produce a disinhibition of the ADH hormone. So maybe ibuprofen is more likely to produce such fluid retention and all these effects. It can cause disturbances in the vision also in the form of toxic amblyopia. And of course, because it is GIT friendly to a large extent, it has gained wide acceptance in chronic treatment of rheumatoid arthritis and osteoarthritis. The GIT effects are less intense as compared to aspirin. So these are the other propionic acid derivatives, learners: naproxen, ketoprofen, phenoprofen, flurbiprofen. Naproxen among these is used for treatment of acute pain of gout. Naproxen is also used for relief of headaches, but it is one of the NSAIDs which is preferred for relief of acute pain of gout. Aspirin, they say, should never be given as a anti-inflammatory in gout because the doses which are its anti-inflammatory doses, which are 2 to 3 grams per day, aspirin has a uric acid retaining action. At higher doses, of course, it becomes uricosuric. I'm talking about aspirin. But at the doses which we like to give to relieve the joint inflammation in gout, those doses have a uric acid retaining action. So, you know, you can have a one marker like why aspirin is contraindicated in inflammation or relieving the pain of acute gout, and that is the answer. Because it has a uric acid retaining action. Now we come to one of the NSAIDs which is actually very commonly given. The name of the drug is diclofenac sodium. Diclofenac is commonly available in the market as a brand name Voveran. It has many other brand names. It is a drug which can be given intramuscularly. It is a drug which can be, given as a topical ointment, topical gel also. It is applied over the joint cavity to bring about some relief from joint inflammation. It is also used as an anti-inflammatory drug for ocular installation. You know, if there is inflammation surrounding the eye, post-operative eye inflammation, it can be used. And it is also approved for long-term treatment of rheumatoid arthritis, osteoarthritis, and ankylosing spondylitis. So it's one of the drugs which is commonly used. Again, it is also less toxic to the GIT in comparison to the prototype drug aspirin. And yeah, it does have its own share of side effects. That there have been reports of association of diclofenac with hepatotoxicity, and that hepatotoxicity, you know, is a idiosyncratic hepatotoxicity. That means we do not know the cause of this hepatotoxicity. It could be dose related, it may not be dose related. So diclofenac is associated, learners, with hepatotoxicity, which you must remember. It is more potent than its congeners indomethacin and naproxen. Its ophthalmic preparation is also available. It accumulates in the synovial fluid, so it might provide a better pain relief or better inflammation relief in patients of joint inflammation. And diclofenac, yeah, it can be asked to you as a short note. Then we come to KETOROLAC. This is one of the NSAIDs which has a very good action as far as the relief of the post-operative pain is concerned. So if you relieve the post-operative pain in NSAIDs, which otherwise you might require the use of opioids, if you use an NSAID, it has a opioid sparing action, which is a most welcome action. So it is the effective analgesic successfully to replace morphine in mild to moderate post-surgical pain. It is also available, it is given intramuscularly, intravenously, and an oral formulation is also available. It has an opioid sparing action. Less we use the opioid, the better it is, because opioids would definitely bring about pain relief, but they could also add to the respiratory depression which the patient has owing to his conditions. It is also having an ophthalmic preparation which is available. Then we have the acetic acid derivatives, indomethacin, sulindac, and ketorolac. Amongst this, indomethacin is a prototype drug. It also has a lot of GIT irritation associated with it. It is much more a potent inhibitor of COX than aspirin. But it is a reversible inhibitor of COX, that is one thing. It differs from aspirin, yes, but it is definitely more potent because the potency is decided by the dose of the drug. Remember one thing, and they say that indomethacin is 20 times more potent, a COX inhibitor. Not only does it inhibit the COX, prevent the generation of prostaglandins, but it inhibits the motility of the polymorpholeukocytes and decreases the biosynthesis of mucopolysaccharides which would participate in inflammation. So that part would be taken care by indomethacin. Also, because inflammation is associated with a vasodilatory action, indomethacin might have a direct cyclooxygenase independent vasoconstrictor effect. Please note this. It has an excellent bioavailability, so when you take it orally, quite a lot of indomethacin is absorbed rather than undergoing the first pass metabolism, and that is it is actually used for two major indications. One is in fevers, which are refractory, especially malignant fevers or autoimmune fevers which are not responding to paracetamol in the highest doses which are tolerated by the patient. Indomethacin might be helpful in such patients because it is not used commonly as an analgesic because of its association with the GIT toxicity. But unless the fever is refractory to other agents, if it is refractory, then we might think of giving indomethacin. Example is fever of Hodgkin's disease. We might, Hodgkin's lymphoma, we might think of giving indomethacin. Indomethacin also has received one FDA approval that in premature neonates whose ductus arteriosus has not yet closed, normally it closes soon after birth, but in patients in neonates whose ductus arteriosus does not close at birth, indomethacin is FDA approved to bring about the closure of the patent ductus arteriosus. Where it is given to the neonates, and because neonates have a very, very less body weight, this drug is given in the form of milligram per kg body weight for 3 such doses, 0.1 to 0.2 milligram per kilogram every 12 hours, IV for 3 such doses. The therapy is indicated for premature infants 500 to 1750 gram weight who have a patent ductus arteriosus. If you go by its mechanism of action, indomethacin should increase the risk of bleeding, increase the risk of hemorrhage in neonates, but it is actually not so. It decreases the incidence and severity of intraventricular hemorrhages in low birth weight neonates. So that is a blessing if indomethacin is doing that. But its principal toxicity is renal toxicity. More so, we have to be careful because the patient here is not a normal or a young adult, he is a neonate, and you know that the renal functions, they take about 8 to 9 months to develop. So till that time, there is a chance of indomethacin induced nephrotoxicity. Students, be careful of that. And indomethacin also causes fall in the platelet count in the form of thrombocytopenias, which could be having an allergic diathesis. Now we come to the long-acting derivatives of the NSAIDs, which are two, piroxicam and meloxicam. They are used for once a day administration, especially they are given at night time, so that early morning joint stiffness because of osteoarthritis or because of rheumatoid arthritis, because of ankylosing spondylitis is taken care of, and it shares its mechanism action a bit with indomethacin, that over and above inhibition of cyclooxygenase, they also have inhibitory effects on the inflammatory cells or the inflammatory processes which are going on. So they do benefit the inflammation irrespective of their COX inhibition, or I would say independent of their COX inhibition. They have a long half-life, they permit once daily administration, and yes, GIT disturbances can be seen with the piroxicam-like drugs. And meloxicam, the congener of piroxicam, is a preferential COX-2 inhibitor. I told you there is a difference between selective COX-2 inhibitor and preferential COX-2 inhibitor. Preferential COX-2 inhibitor will also inhibit COX-1, but in the dosage which we are planning to give them, they will inhibit the COX-2 earlier, so they will take care of the inflammatory part with less GIT irritation. Of course, at higher doses, meloxicam does become non-selective and safe. Its dose is 7.5 to 15 milligram once a day. And that is the only NSAID which is actually not an acid. I told you all NSAIDs are organic acid, barring one, nabumetan. But in the body it gets converted to an active metabolite, which is an acid. So all NSAIDs are acids. Yeah. The dose typically is 1000 milligram, which is given once daily. It's a prodrug and it's get converted to the active metabolite 6-methoxy-2-naphthyl acetic acid, which is an inhibitor of COX-1 and COX-2. Now these are the individual NSAIDs for an undergraduate level. I think they are sufficient to be covered, and just recapitulating what we had read over these 4 sessions. Because aspirin inhibits cyclooxygenase very effectively, it also undergoes the phenomena of iron trapping. So upper GIT disturbances are very common, very common as compared to other drugs and indomethacin, both aspirin, indomethacin, to cause upper GIT disturbances. Diflunisal, because it has no penetrability across the blood-brain barrier, it cannot reach the temperature set point in the hypothalamus, has no antipyretic activity. Remember, the learners, does not have any antipyretic activity. Indomethacin, I told you, is very potent, but should be used as a reserve and safe only after less toxic agents have proven ineffective. I told you fever of refractory origin we can take care of indomethacin. CNS disturbances in the form of dizziness, headaches are very common with indomethacin. And ibuprofen, if you see, I've not labeled it, but it is having more risk of aspirin-induced asthma. And yeah, this one, the COX-2 inhibitors, celecoxib, rofecoxib, many of them are withdrawn now. They have a potential for increasing the myocardial infarction and stroke. They should not be given just routinely. As far as the advantages of aspirin are concerned, no other drug has made such a significant difference in the therapeutics as aspirin has. When I say that, I refer to its antiplatelet low-dose aspirin. Aspirin is the cheapest drug available, and it has a long history of safety. Diflunisal has less GIT irritation than aspirin, and Sulindac, it gets converted to a drug which is called Sulindac sulfide. Sulindac itself is a prodrug. It gets converted to Sulindac sulfide, and it has a long duration of action, so which permits a once daily dosing. All the propionic acid derivatives, whether it is ibuprofen, naproxen, they have lower GIT toxicity, and naproxen, is considered by some experts as one of the safest NSAIDs. Piroxicam, meloxicam, I told you, are having a very long half-life, so they can be given just once a day. Mefenamic acid is having GIT side effects, but mefenamic acid is usually reserved for young ladies who are having dysmenorrhea, that is painful periods. And celecoxib, of course, it does not have any GIT irritation, as compared to its other congeners. So that is about the individual NSAIDs. Now let us have, you should know that drugs can themselves cause musculoskeletal disorders. We are giving the NSAIDs for treatment of musculoskeletal pain and all those things, but drugs themselves can be culprit of any disease. Drugs can be culprit for any disease. So let us see which are the drug-induced musculoskeletal disorders. Some drugs, they can produce an anti-nuclear antibody in the body, and that can lead to a phenomena which is called drug-induced lupus. Now, drug-induced lupus is more common in the drugs which are acetylated in the body, and they include isoniazid, they include procainamide, and they also include the drug dapsone, which is a drug for leprosy. So you should know which are the drugs which can produce lupus. One of the other drugs, which is an antihypertensive drugs, which is hydralazine, it also has incidence of drug-induced lupus, which is seen more commonly in women. So let us have the drugs which can produce drug-induced lupus. It may not always be autoimmune, it might be because of the drugs. Procainamide, which is an antiarrhythmic drug, hydralazine, which is an antiarrhythmic drug, hydralazine hydrochloride, isoniazid, which is an antitubercular drug, quinidine, which is an antiarrhythmic drug again, and phenytoin, it can produce drug-induced lupus, and dapsone, it can also produce drug-induced lupus. Now, there are some drugs which can precipitate an acute gout. Patient is normal, he doesn't have any history of hyperuricemia, but there are some drugs which can produce gout, which can, gout is frequently recognized when there is a swelling of the big toe. There's a lot of pain, excruciating pain, and it could happen in a gentleman who has actually consumed a lot of alcohol on Saturday, and he might have a swollen big toe on Sunday. That means he has an attack of acute gout because of alcohol consumption. Alcohol produces hyperuricemia, so that could be one of the reasons for alcohol-induced gout. So students, be careful. Low dose aspirin, that means I would not say the dose which is meant for cardiovascular prophylaxis, but the anti-inflammatory doses or analgesic doses have a uric acid retaining action. The analgesic and the anti-inflammatory doses of aspirin have a uric acid retaining action. So that is why they are not to be used in acute gout. It themselves can cause hyperuricemia. Then we have the diuretics, both thiazides and loop diuretics. The interference with respect to uric acid secretion inside the tubules is competitively inhibited by these diuretics. So thiazides and furosemide both are linked to the development of hyperuricemia and gout. Gout can happen, if there is a sudden lysis of the cells also in the body, and that is brought about in the therapy of the poor cancer patients who receive a lot of cytotoxic drugs, and they land up with hyperuricemia, because that uric acid is the end product of purine metabolism. So cells get lysed, so more of purine is generated, more of uric acid is formed. Alcohol, as I told you, it inhibits the uric acid secretion, and it also enhances the degradation of adenyl nucleotides in the body, and that could be the reason for alcohol-induced gout. The anti-cancer drugs I have already talked about, and pyrazinamide and ethambutol, pyrazinamide and ethambutol, they are antituberculous drugs, and more pyrazinamide, less ethambutol have been linked with the risk of hyperuricemia and gout. So students, drugs can cause any side effect, it can lead to any disease. And the diseases which drugs cause, you're not taking drugs, the patient is not taking drugs on his own. The patients are taking those drugs which are prescribed by his or her prescriber. So these diseases which emerge because of the drug use are often called iatrogenic diseases. So these could be presenting themselves as iatrogenic diseases. Of course, iatrogenic diseases can take up very serious and severe proportions, but you must remember this, iatrogenic disease. There are some drugs, which can cause muscle cramps, and these are those drugs which can cause protein catabolism. These are those drugs which can cause hypokalemia, and if I talk about catabolic drugs and hypokalemia, the first drug which comes to my mind are the glucocorticoids. The glucocorticoids are known to cause muscle cramps. Then the statins, HMG CoA reductase inhibitors, they cause significant myopathy, and that is a reason because they inhibit the cholesterol synthesis in all the cell membranes, which may or may not be invited. So HMG CoA reductase inhibitors, they can cause muscle cramps, especially if you are giving high doses of atorvastatin, not a 10 or 20 milligram dose, but 60 milligram dose or 80 milligram dose. We can invite myopathy over and above if the statins are combined with fibric acid derivatives in the form of gemfibrozil or other type of fibrins. This particular problem can be enhanced. The diuretics, because both loop diuretics as well as furosemide and thiazides, they cause hypokalemia, so they can be the reason for muscle pain cramps. Succinylcholine also can cause muscle pain cramps because it is a depolarizing type of neuromuscular blocker, and it does cause transient fasciculations before finally going for muscle paralysis. So those transient twitchings and paralysis fasciculations can also lead to muscle cramps. Clofibrate, which is a lipid lowering agent, and more so when these are combined together, HMG CoA reductase inhibitors are combined with clofibrate, this myopathy or muscle cramps could be increased. And this is a drug interaction, students. Because what happens is that normally the statins are taken up by the liver by a transporter, which is an OATP transporter in the liver. So if the statins are taken up by the liver, they are spared from the systemic circulation. Okay, and what does clofibrate do? Clofibrate inhibits the transporter which takes the statin inside the liver. So the statins have a systemic exposure they go to every cell membrane. They inhibit cholesterol synthesis everywhere, including the muscle cell membrane, and that is the reason for the muscle cramp. So this drug interaction, is asked as a credit question, HMG CoA reductase inhibitors with fibrates, and you just have to say that this is a drug interaction at the level of the drug transporter in the liver. So remember this, students. And the glucocorticoids, they cause a negative catabolic effects on the body, as well as they also cause hypokalemia because they cause sodium and water retention. So they cause hypokalemia or fall in the potassium levels that will cause muscle cramps in a patient. Estrogen and progesterone oral contraceptives are also implicated for development of muscle cramps. And succinylcholine, I told you it's a depolarizing type of neuromuscular blocker. And there are some drugs, which can cause bone growth inhibition also. Every organ of the body can be affected by drugs, and the affection depends on where the drug accumulates itself. That is where it is going to cause the damages. But we are specifically focusing right now on the drug-induced musculoskeletal disorder. So we have focused on the drug-induced lupus, acute gout. We have also focused on the muscle pain cramps, and we are now focusing on the bone growth, which are inhibited by the glucocorticoids because of their decreased effect on they have a negative calcium metabolism. They also decrease the effect of vitamin D on the attendant calcium metabolism. As a result, the calcium comes out of the bones get weaker. And tetracyclines, are metal chelators. They are going to combine with the calcium in the growing bones, form tetracycline calcium complexes, which might have not a good effect on the bones. And finally, there are some drugs which can cause osteoporosis. Heparins, both unfractionated heparin as well as low molecular weight heparins, corticosteroids because of their negative effects on the calcium balance, and because they inhibit the vitamin D action also. So calcium has to come from somewhere inside the blood. So the bones, the parathyroid hormone gets stimulated, and because of less calcium in the body, the parathyroid hormone gets the calcium out from the bones. So that is going to lead to weakening of the bones on long term. Even methotrexate sodium causes osteoporosis, and I would also like to mention phenytoin because it enhances the metabolism of vitamin D. Phenytoin is a cytochrome P450 enzyme inducer. It not only metabolizes other drugs, but it also enhances the metabolism of endogenous products in the body, for example, vitamin D or folic acid. So in the presence of phenytoin, we might expect vitamin D action to be lost, and that is why on long term it can cause osteomalacia and osteoporosis, a weakening of the bones. So students, thank you very much, and this was the fourth and the last talk on the NSAIDs, and now I would like to, in the next session, which will be soon aired, I would be talking about the opioids. You know, the opioids are God's own medicines, and they can relieve any kind of pain. The NSAIDs might be limited as far as relieving the pain of terminal illness or some pains are concerned. They might not be useful. But opioids, you know, they can abolish, eradicate, whatever the word you want to tell, any kind of pain, students. So my next session, be on the lookout, would be on the opioids. So we are sailing too nicely for our pain relievers. Please, if you have some query, do put in the comments, and we would be highly obliged to answer that. Then and then only I'll feel that whatever we are doing, whatever efforts we are taking, is bearing some results for the part of students it is aimed at.